Hi, I'm Dr. Suresh Ramalingam, thoracic oncologist at Emory University and the Winship Cancer Institute in Atlanta. For patients with the EGFR exon 19 or 21 mutations, osimertinib has emerged as the preferred first-line therapy. Now, when you think about osimertinib, it has several advantages over the first and second generation drugs. Number one, it is specific to the mutated receptor with more than 200-fold selectivity for the mutant versus wild-type receptor. Number two, it not only blocks EGFR exon 19 and 21, it also blocks the T790 mutation, which is the most common resistance pathway when we treat patients with first or second generation agents. Number three, osimertinib also has good activity in the brain. It penetrates the blood-brain barrier and has activity against brain metastases. And finally, it has a better safety profile. Now, we saw from the FLORA trial that osimertinib showed superior progression-free survival, and it improved overall survival when compared to erlotinib or gefitinib. So these are the results why these are the reasons why we use osimertinib as the preferred frontline therapy agent. It's FDA approved in that space. It is recommended by NCCN guideline as the preferred drug. Some people have suggested the possibility that you could give first generation or second generation drug first, and then when patients develop resistance, look for T790. And if they have T790, you give them osimertinib. Well, that is exactly what we did in the FLORA trial. Patients in the control group of FLORA trial were treated with gefitinib or erlotinib. And at the time of progression, if they had T790, they were allowed to cross over and receive osimertinib in the second line setting. And in fact, more than 30% of the patients who were candidates for crossover therapy ended up getting crossover therapy. Despite that crossover, we saw an improvement in overall survival. Osimertinib had a median of 7-month improvement in overall survival in the FLORA trial with a hazard ratio of 0.8. So to me, the sequencing approach of using a less effective drug in the first line setting and waiting for resistance and then using osimertinib in the second line setting is not based on good evidence. The other thing to keep in mind is when patients receive frontline therapy, there's a 30 to 40% chance that they will never receive any second line therapy. That's because they may develop more rapid disease progression, or something else could happen to the patients that limit their ability to receive second line therapy. So for those patients who have the opportunity to receive only one active drug, we want to make sure that that's the best drug that we have to offer them. So in oncology, we've always used the best drug first approach to treat patients. And in my view, osimertinib being the best EGFR inhibitor in class is the most suited for frontline therapy.